So welcome everyone to the Human Immunodeficiency Virus Boot Camp. This is session 1. The goal is to give you a rapid knowledge infusion about human immunodeficiency virus and to essentially make you very comfortable in treating those living with HIV. First of all, I want to start, if anyone knows who this young gentleman is. This is Ryan White. He contracted HIV through a blood transfusion. He was diagnosed at age 13 in 1984, and he unfortunately was the victim of much discrimination, people protesting not wanting him in schools. And despite all of this, he and his family had a lot of courage and worked tirelessly to get care to those with HIV and to bring awareness and decrease the stigma surrounding HIV. The federal government of the United States, since named a Ryan White Care Act after him in honor of him and his work to provide care for HIV. And now in the United States, there are Ryan White clinics that are federally funded, and these clinics assure that people with HIV will get care and access to medications. Here at the Florida Department of Health in Hillsborough County, the Specialty Care Center is a University of South Florida Tampa General Hospital academically affiliated Ryan White clinic. We are federally funded through the Ryan White program. We have 2,100 to 2,500 unique clients in any given year. We are multilingual. Our staff speaks English, Spanish, Tagalog. We have patients who also speak Vietnamese, Haitian Creole, and we have some Eritrean languages as well. We are multicultural, transgendered, and LGBTQ friendly. We partner closely with the Ybor Youth Clinic, which is our pediatric infectious disease affiliates, and all patients are accepted and provided HIV care regardless of insurance or citizenship status. We have an on-site dental clinic, a nutritionist, case management social work, a licensed psychologist, social worker, and we are now ramping up again our women's health for pap smears, anal smears for cervical and rectal regions. We also do colposcopy and anoscopy. We did that in the past. We're ramping that up currently as well. I wanted to share with you the greater macro level of HIV infection in the United States. These are new diagnoses, so these are incidences of HIV in the United States. 2004 was the latest that I could find in the CDC. You'll see hotspots of HIV incidents are the Southeast. There's New York, New Jersey. There's Texas. But you can see that about 50% of all new infections are in the South. That's about 22,000. Also, highest prevalence of HIV, a little bit less than 1 million. Again, this is the latest slide. Is also in the South, and that's about 42%. So the Southeast still has a lot of challenges. Working with HIV, certainly you see New York is also dark purple there, but we certainly have a high burden as well in the Southeast. The HIV surveillance report, this is from the CDC, breaks it down a little bit by populations. Why this is important is because it helps public health messaging and population studies and the epidemiological educational piece in terms of tracking infections. Some groups are higher infections, so our African American MSMs, especially our young MSMs, are right now the most at risk and most vulnerable for HIV infections, especially in the Southeast. Our Caucasian MSMs have seen a little bit of a decrease. Our Hispanic Latino MSMs have seen an increase. So the epidemic has changed a little bit in terms of demographics, and our challenge is to obviously decrease infection for all groups, but also to make sure that we're reaching everyone and trying to get that message across. In the Southeast, especially in Florida, unfortunately ranked number 1 for HIV infections. New diagnoses 2013. That data since has been reworked, and we're thinking it's a little bit less, but as it stands, it still was a very high rate, especially 11.4% were diagnosed of all new infections, mostly through MSM transmission. very low rates currently of IDU in Florida. However, that is rising. And we're working on decreasing those rates. Those rates have since come down in Florida through enhanced epidemiological and messaging campaigns, but still have a lot of work to do. This is Florida specifically. You can see this is on AIDS View, which is publicly accessible. You can see the dark areas here. A lot of infections around the Miami area, a lot around the Hillsborough-Pinellas area as well. And this is a smaller view as well. This is helpful, again, for messaging, funding, community center funding, and prevention efforts. This is a treatment cascade for Florida. So currently we only have about 58% of our people living with HIV controlled, meaning suppressed HIV viral load, and we have estimated about 13% of our folks still undiagnosed. This is a treatment cascade that you've seen, I'm sure, on a national, international level. This is showing us that despite about 100,000 people that we have with HIV, only 90% get into care, 64% are retained in care, so they have 2 documented visits at least 3 months apart, and 64 are actually on antiretroviral therapy, and then only about 50% have a suppressed viral load, less than 200 copies per milliliter. And that's what we are now. We hope to bring that up to 100%. This is also an interesting slide because folks with HIV have systemic inflammation, so it's so important to get them into care because they can develop cancer at earlier ages than those without HIV. So, for example, the blue is in the HIV positive individuals, the red is in HIV negative. So those who have HIV, you can see, are getting cancers at earlier ages. Some of these overlap, I would say. Probably liver cancer, so hepatocellular carcinoma, lung cancer, and prostate cancer, including breast cancer. Certainly cervical cancer are higher rates in those living with HIV. The number of HIV positive adults aged greater than 60 years is increasing in the United States, so we have a increasing geriatric population in the United States living with HIV. This is important for multiple reasons. Number one, we start getting into chronic illnesses, so management of diabetes, stroke, hypertension, heart disease, and also HIV dementia is always looming as a diagnosis as well. Thankfully less with well-controlled viral load. But the needs of our population is becoming more merged with our geriatric population, estimated as about 35.2% in 2010 and rising. So to get into the basic science a little bit, HIV, human immunodeficiency virus, is a retrovirus, and what that is, it's basically it's retrovirus because it doesn't follow the similar pattern, so the way that it replicates is backwards than many of the other viruses. It's also called a lentivirus because it moves slowly, so folks can get infected and not really have signs of the infection for 10, 20 years. More so, usually about 10 years is the average. You can see the important parts here is the P24 protein on the envelope. That is a marker that we use for diagnosis. There's some other markers, VPR, which we look for, GP41, GP120. Those are also important to understand. And then this is the virus on the inside. The HIV life cycle. You can see the virus, like many viruses, it docks to the CD4 plus T cells. So you have lymphocytes, you have B and T cell lymphocytes. The T lymphocytes, you have CD4 plus, you have CD8 plus, and this is a CD4 cell trophic cell. So you can see the HIV virus actually finds and hunts down, unfortunately, the CD4 cell. It's attracted to that and fuses in that GP120 area, and actually fuses in there, kind of like a docking spaceship. And what it is the HIV RNA is then kind of inserted into the cell, and it's called a retrovirus because it goes from RNA to DNA. Many viruses go from DNA to RNA. So the machinery is a little bit, it's actually backwards for HIV, which makes it a complicated virus. So it actually goes into the cell. You can see it uses reverse transcriptase to make the RNA into DNA. It integrates into the cell. So it's very difficult right now to cure HIV because there's always reservoirs because it's integrating into the human genome. We're working on fleshing out those reservoirs, but we're still not quite there yet. Once the virus is then it's integrated into the host DNA, and it makes new viral RNA, and this new viral RNA is used to package up and make new virions that butt off, and the cell unfortunately is just taken over by this virus and becomes kind of a machinery to make virus, and then the cell dies. The spread of the virus, or how much viral load, is basically how many virions are in a portion of the blood, and there's more information here on the NIH site. So our medications actually work to stop the process at all these sites. So the fusion inhibitors try to stop the fusion of HIV to the cell. The non-nukes and the nukes, as we call them, the nuclear reverse transcriptase inhibitors and the non-nuclear reverse transcriptase inhibitors, those work essentially to stop the replication based on specific DNA codons. The integrase inhibitors stop the integration of the DNA, in the viral DNA, into the host DNA. And the protease inhibitors stop the budding off, so the protease helps make viral proteins, and then the maturation inhibitors stop the maturation of the HIV, the budding, if you will. And the reason why the red is circled in the integrase inhibitors is because that is the most commonly used medication and preferred antiretroviral. Integrase inhibitors are really becoming first line for HIV therapy. This is the natural progression of HIV. This is a classic slide of which you should be familiar. You can see in the blue is the CD4 plus T lymphocyte count. Normals around 1,200, 1,100 around there. With primary infection, the CD4 count drops precipitously and then continues to drop. You can see the arrow, and then the viral load in red will increase very rapidly and then stabilize. So most folks in this area, it's called clinical latency, don't know they're infected, and this is where the virus is somewhat controlled and a lot of transmission can occur. And then we see that the host just really becomes worn out and it kind of takes off in terms of replication, and the host becomes rapidly ill and usually comes down with opportunistic infection. So unfortunately, we see a lot of people present at this stage where the virus has already replicated, the cells are already destroyed, and the person has opportunistic infections such as pneumocystis pneumonia and cerebral toxoplasmosis. And so our goal is to try to get people not only not to get the virus, but to be treated and tested earlier so they don't come down with opportunistic diseases later on, which means that it's harder to get the immune system to be stronger when the infection is found later down the road. This is important because of the docking mechanisms we talked about. So the virus docks to the lymphocytes like we talked about, but there are two methods that it can dock. It can do a CXCR4 docking or a CCR5. Those are the types of receptors, and why that's important is some of our meds work on that CCR5, specifically Maraviroc, and it's called a tropism, and we have to check their tropism to make sure that medicine will work. But just so you know, people can change their tropism during the course of infection. So people could be an R5 and then become an X4. So just something to consider. So HIV does evade the immune system, and it does establish latency. As we talked about, it integrates into the human genome. This is important because it's very hard right now to cure HIV. There has been one cure with Tom Brown, but that was in bone marrow ablation. There are probably, since this talk has been recorded, there's probably more science to that. However, you can see that this is where HIV will establish latency. So it can be suppressed but not cured right now. And it does devastate cellular response and humoral response. So what is an HIV non-progressor? Those are folks who have the HIV confirmed, but their viral loads are very low or undetectable, and they do not see a very dramatic decrease of CD4 count cells. So this is about 5 to 15% of those living with HIV. And we think that's a genetic attribute, and it has to do with how their CD4 cells receptors are configured, also known as long-term survivors. Now, there's also something called elite controllers. Those are very rare, but that's a subset, and they have undetectable viral loads without any antiretroviral therapy. They're very few and far between, and the NIH is studying these folks very closely. Why? Because the CCR5 delta gene can be, if there were two of those, it's very difficult for the virus to dock on the CD4 cell. And that's what we think is the mechanism, and we think it was probably evolutionary for resistance to plague or smallpox. And in the Tom Brown patient, that is, he received his bone marrow transplant from a patient, a donor who was homozygous, and so that was the goal, was to try to prevent HIV from replicating. So HIV does cause accelerated aging. There's chronic inflammation leading to immune activation and an immunosenescence, and this is why we think we have higher rates of cancers and other comorbidities with uncontrolled HIV. There's even some evidence that with controlled HIV there's still higher morbidities and mortalities, but certainly when the HIV virus is not controlled, that is more of a problem. So just a little bit to understand what happens when HIV is into the host. You can see here in the arrows with acute infection, first one is going to be able to detect the viral load here, and then the P24 antigen is able to be detected, and then like most viruses, it takes a while for the body to make antibody, and so the antibody is detected later. Why this is important is in the early days of HIV, we could find the antibody, but sometimes that would be very late. We could certainly look for viral loads, but now the fourth generation immunoassay is almost 7 to 12 days after infection, and we can actually find almost within 10 days if we check a viral load. So if someone presents with a rash and a fever and a history of exposure, then probably a good idea to get the viral load and that fourth generation test, which is a combination antibody-antigen test, and it's very specific and sensitive for HIV infection, and that's the area right there. So at Florida Department of Health, we're still using a third generation. I think we tried the fourth generation, but there were some problems with that. But generally speaking, the fourth generation is very, very helpful, and that's a serum test. We actually don't do the Western blots anymore. There's a great blog by Dr. Paul Sachs about that, but that is not used anymore. It was we have other faster and more efficient tests now. And we're using the third generation currently at our clinic. These are rapid tests, so people can actually get tested, buy the test in the CVS or Walgreens or your drugstore and get tested. Clearly, we like to have people counseled and tested, but one can get tested with a over-the-counter kit, if you will. This is great, the OraQuick, just because it's a very mobile. Yale University has a wonderful community healthcare van that they are able to test for rapid HIV and Hep C using the OraQuick platform, and that's very, very helpful. It's about 20 minutes. It's a finger stick for the Hep C, and it can be an oral for the HIV. You can also do finger characteristics for HIV as well. Laboratory regimen and HIV care. Essentially, this is something to remember, kind of the nuts and bolts of how you take care of patients living with HIV. Every 3 months, we usually recommend a HIV viral load, CD4 count, CBC, and CMP. It's called a basic 4 in our clinic. Guidelines are if you have a controlled viral load within about a year, you can move to every 6 months, which is very helpful for your compliant patients who remember their medications. Yearly, we like to do a sexually transmitted infection screen, an STI screen. So that includes a urine PCR for chlamydia and gonorrhea, and a serum assay for RPR to a reflex titer. Remember, a treponeme IgG, once positive, usually always positive, so not so helpful if they've had infection before. The RPR is a little bit easier to monitor. And you want to either do serial RPRs or serial VRDLs. We use serial RPRs, it's worked pretty well. And then would recommend also throat and rectal STI screens for chlamydia and gonorrhea. There are a lot of cases and also documented literature of people with negative urine screens but positive throat and rectal. Why that's important is because untreated infections can cause strictures and can cause other kinds of problems, and sometimes rectal infections need to be treated for 3 weeks if it's an LGV strain of chlamydia. Fasting lipid profiles are important for our patients. They're same with yearly tuberculosis screens. We use the serum, the IGRA, interferon gamma release assay, either a T-spot or a quant gold. We like the T-spot because it creates a lawn, if you will, a LAWN of T cells, which is a little bit better in immunocompromised individuals. And then we work for our preventative medicine, make sure our patients are up to date with mammography, colonoscopy, and thin prep smears. And we always want to check our hepatitis A and B serologies. What I will say about that is hepatitis A IgG is really what you want. Hepatitis IgM is, of course, a new infection. You want to know if they've been infected in the past, unless you have a new presentation. And then hepatitis B is a little more complicated, but you want a surface antibody, surface antigen, and a core antibody. If they have a core antibody, it means that they have had infection in the past. Surface antigen means they're still actively able to transmit that infection, and surface antibody means they're immune. Quantitative is really what you want, more than 10. Qualitative is a good start, but you really need to have them over 10 to be immune. And hepatitis C antibody. Toxoplasma IgG is a once lifetime screen, and really only relevant if they have a low CD4 count. HLA B5701 is a helpful genetic screen. If you need to use a bacavir, you need to have this tested first, and then it's an optional to test for G6PD activity for using Bactrim or Dapsone. Generally, we just start either Bactrim or Dapsone, but certainly helpful if you're concerned, you can check for activity. The first patient encounter, similar to other specialties, you really want to take a good chief complaint, history of present illness, review of systems, vital exam, laboratory radiology, pathology review, assessment, and plan. You really need to make sure that you know what medications your clients are on. You need to know their psych meds, their cardiac meds. You need to get the name of their providers and make sure that they're reconciled. If you need to, call up their pharmacy. Very, very important in outpatient medicine with HIV to make sure you don't have interactions and to make sure that you're up to date. If you change ARTs, be sure to delete the old ART from the profile and make sure that the pharmacy knows that you're changing as well, especially if it's multiple pill regimens. And also, you need to make sure that you're faxing your notes to relevant providers in your patient's panel. You always want to update your sexual history and substance use history, mental health history. Using validated scores are helpful, and also making sure your vaccinations are up to date. Florida has Florida Shots, which is a statewide vaccination database, A, B, and C, including Pneumovax, PCV13, PPSV 23, and influenza and Tdap. You want to confirm their pharmacy. I have to tell you how many times we've written prescriptions and it's the wrong pharmacy, and then we have to write them again, and it's a multiple day delay. So just get the pharmacy please confirmed, and it'll save yourself a lot of trouble. And I usually give about 6 refills because it's a lot easier, I think, to just have that prepared for your patient. And also, I always confirm their telephone number and their cell phone number, and encourage them to identify themselves on the phone and ask if they share a phone and if they would like you to leave a message or not. Remember, we're working with vulnerable populations with high mental health comorbidities. A lot of folks have a lot of transportation difficulties, especially in the Southeast. We don't have good working metro stations, so it's very difficult for people to take 2 buses and leave work. So we always make an effort, no matter what time they arrive, we see them. If they come to triage, we see them. They definitely have difficulty coping with stress and schedules, and are living with daily stigma, poverty, stress, and interpersonal and domestic violence. So we really try to be sensitive to the whole person. Another challenge we run into is frequently changing insurance status, which is really a challenge because you get someone very controlled on an antiretroviral medication, and then their insurance changes, and then you have to start them on another one or try to justify why you're keeping them on the same one. So that is, prior authorization is a big headache, but you want to make sure that you have a mechanism in place. So we work as a team to get the forms already filled out, so we just process them more quickly. Our clients also have frequent travel, and often folks are migratory workers, so we try to make sure people have enough medication to last them until their next appointment. We also have a lot of clients who are still finding gender self-identities, so a lot of, internal searching going on there as well that we want to give support. And then many of our folks are going in and out of the incarcerated setting, and that means that's a challenge to keep them on their medications and get them back into social services. And also many of our clients may need multiple medical referrals for, we do manage diabetes, but if it's very complicated heart problems, etc., or surgical problems, they'll need referrals. Terminology in HIV Care. The older term is highly active antiretroviral therapy, because there was some of them were not as active and some of them were highly active. We kind of just say ART right now. It's kind of a general term because all of it's highly active. The older term, AIDS patient, we don't say that anymore. We say people living with HIV or AIDS, because we have very few inpatients, thankfully, for HIV. The older term, IVDU, IDU, IV drug abuse, we really like to say people or persons who inject drugs. And remember, people who inject drugs can remember their ART. We just have to work with them and try to find out the reason why they're injecting and try to get them the help they need. Domestic violence is an older term. Newer term, intimate partner violence or interpersonal violence. We don't say heroin addict or cocaine addict. We say heroin use disorder or cocaine use disorder. We don't see alcohol abuse or alcoholism. We really have an alcohol use disorder, and there are ways to actually quantify that. So your first patient encounter, be patient with yourself and your client. See patients, obviously, if they arrive a little early or late. Budget time for triage patients, because you're going to have some people coming in to want to see you and who have issues to address. Refills are super, super important. So all of your paper electronic refills that you get, please process appropriately and make sure it's the right pharmacy, because if you forget or get too busy, they can really be at risk for rebound viral load, and that is definitely something that we want to avoid. You can also mail meds, so talk to your patients about pharmacies that mail meds, and follow-ups are super important in terms of making sure that you're processing messages that get to you when you come back into the office. Lab reviews certainly are important, but also tracking creatinine. So if you get a lab review back with, creatinine level there or an RPR there, you really need to go back and see what the trend was. Is this going up? Is this going down? What is the history? What meds are they on, especially for high creatinine? Are they still on the old tenofovir regimen, the TDF? Do you need to change them over? Do you need to change their frequency? So a lot of labs in HIV, you really have to have a context, and you really need to know their prior labs and their meds to really make an informed decision. And the ADAP is an excellent program called the AIDS Drugs Assistance Program, and getting to know your ADAP folks is important because they can help you get your patient on meds. So a few cases, presenting patient format. This is a 68-year-old gentleman. This is how you want to say when you present. So you want to say this is a 68-year-old gentleman living with HIV with a CD4 count of 211 and HIV viral load of less than 20 copies, last drawn on X date. He's well controlled on which ART, and relevant history. So TB is obviously a very important history. Diabetes is also very important. Any opportunistic infection is a very important history to mention right in that first sentence. So you have the age, you have the CD4 count, the viral load, when it was done, controlled on what med, and what are the relevant histories. I think it's helpful also to mention the hepatitis B core status, because that's relevant in terms of if that's being suppressed appropriately by ART, and then also helpful to say his hepatitis C status as well, because it's a nice background, because if he's coming to you with abdominal pain or rash, then it's nice to know what his hepatitis status is for A, B, and C. These are resources for the National HIV Guidelines. Clinical Care Options is excellent. They have downloadable and PowerPoints. Of course, the HIV Guidelines is key, and I would bookmark that. Dr. Paul Sachs does a ID blog series. He's very, very witty and very well informed. And the Stanford HIV Genotype Resistance Library, if you're trying to get new regimens for your patients, is very helpful. And there's also a clinical consultation center. So thank you so much for your attention, and we'll see you at the next boot camp.